Hello and welcome to the Urea Cycle Disorders Echo, The Essentials, a series brought to you by the National Urea Cycle Disorders Foundation and the Urea Cycle Disorders Consortium in partnership with Project Echo. This is the last session of our four-part Echo series for 2025. Today's session will feature Dr. Laura Konczal of Cleveland speaking on long-term management of UCDs. My name is Jill Williams. I'm Deputy Director of NUCDF and a UCD family member. I'm leading today's session today on behalf of Teresa Warner, our Executive Director. At NUCDF, our mission is to save lives and improve outcomes for people affected by urea cycle disorders. We believe this four-part series will move us closer to our goal of rapidly diagnosing, effectively treating, and curing UCDs. The ECHO series and our ability to offer continuing medical education credits for healthcare professionals is supported by the families of NUCDF. We want to thank you for your commitment to sharing our mission by being here today. We're pleased to have Dr. Laura Konczal with us today. Dr. Konczal is the Director of the Division of Inborn Errors of Metabolism within the Center for Human Genetics and Genomics at University Hospitals of Cleveland. She received her medical degree at Wright State University College of Medicine in Dayton, Ohio. While in medical school, Dr. Konczal spent a month working with Dr. Carey, Dr. Opitz, and Dr. Longo at Primary Children's Hospital in Salt Lake City, Utah. This is where she met her first patients with urea cycle disorders and was inspired to pursue a career in medical genetics. Dr. Konczal was mentored by Dr. Douglas Kerr, Dr. Sean McCandless, Dr. Charles Hoppel, and Dr. Arthur Zinn. It was through their mentorship that she was introduced to the Urea Cycle Disorders Consortium, taking a role as a co-investigator beginning in 2008 and becoming the UCDC site primary investigator in 2021. Laura, thank you for joining us today.
Thank you for inviting me. It's very exciting to talk about the treatment options that we have that have been developed over the last few decades to make lives better for patients with urea cycle disorders. And then even more exciting to look at the future and the clinical trials that are in development currently that may have an impact on our patients and give them even better quality of life, or even potentially, hopefully, cure their diseases. So these are my disclosures, and I will go over those in detail. Next slide. So the objectives of this ECHO are to review the timeline of the urea cycle discovery, and then the development of the current therapies that we have for the treatment of patients with urea cycle disorders. We'll discuss in detail our current treatment options, including acute management for patients when they are in crisis, and then also the chronic management of patients long-term once they are stabilized. What medications do we have available and methods to keep them stable? We'll also spend some time focusing on liver transplantation, since that is a common treatment option for many patients, especially with proximal urea cycle disorders. We'll also talk about the limitations of our current treatment options and why we need to pursue new treatments and potentially life-changing treatments that in the future could be a cure. We also will discuss up and coming clinical trials that are options for urea cycle disorders, and those that are pending approval that have been through clinical trials but are not quite available. And then we'll also talk about future therapies in the preclinical phase that are in animal models but may be coming in the near future. So I will just touch on briefly where we began. The urea cycle wasn't discovered until 1932, so it's been less than 100 years. And in that original knowledge of the urea cycle, they knew there was ornithine, citrulline, arginine involved, and that urea came out. And that's pretty much it. As time went on in the 40s and 50s, more research was done. They found additional metabolites in the urea cycle, developed a greater understanding. And then the first urea cycle disorder that actually affected patients was not discovered until 1958, and that was argininosuccinylase deficiency. The first proximal urea cycle disorder, OTC deficiency or ornithine transcarbamylase deficiency, was not discovered until the early 1960s, and that is our most common urea cycle disorder. Next slide. So this just illustrates how we went from very basic knowledge to knowing what enzymes are involved, all of the intermediates of urea cycle. And through that understanding of the urea cycle and how it works is how the development of treatments came about. Next slide. So the very first way of treating patients with urea cycle disorders was through diet. So it was not until the 1980s that it was thought, if we restrict protein in the diet, provide just the essential amino acids that are low in nitrogen, could we help our patients to produce less ammonia? So it was in 1982 that this was implemented, and there were a couple of boys who were able to survive beyond the age of 4 with OTC deficiency. And this is the severe neonatal form that people think of when they think of OTC deficiency. We now know there are much milder forms, people who have partial enzyme activity who may not present in the newborn period. But from this discovery, there was the development of metabolic formulas that became commercially available. And then moving on from just dietary interventions, we were able to figure out ways to get rid of ammonia, to scavenge ammonia before it actually got into the urea cycle and before it ever became ammonia. So Dr. Batshaw in the 1980s first used sodium benzoate, and I'll talk about that in a little more detail later, as well as L-arginine to help drive urea production. So that was the very first treatment used, sodium benzoate and L-arginine. We still use those today. About a year later, phenylacetate, sodium benzoate, and L-arginine were used in combination. The phenylacetate and sodium benzoate are what we use today as the IV form of Ammonul when patients are in a very acute crisis. So that came about in the 1984. That was developed, and that was used in conjunction with calories, dextrose lipids to help reduce ammonia in proximal urea cycle disorders. In the very early 90s, we had the first FDA-approved urea cycle disorder treatment, which was phenylacetate, which is a component of the IV Ammonul. And a few years down the road, in 1996, sodium phenylbutyrate or butanol, which many of us are familiar with and much more commonly used, that became FDA approved. So while everyone was working on the ammonia scavengers, there was also some thought that if we replaced the liver, since we now understood that that is where the urea cycle actually functions, that we could treat people with urea cycle disorders. So in 1989, Dr. Corson performed the first liver transplant, and that was in a patient with OTC deficiency. And that was in the early years. As time has gone on, liver transplant has become much more common. In 1999, the first gene therapy trial was underway. And in that trial, they were treating patients with OTC deficiency using an adenovirus as the virus to carry that working human OTC gene into the patient's liver. And they did treat a few patients. Unfortunately, there was a severe event where one of the patients actually died during the treatment, and that put a hold on our progress in the gene therapy world for several decades. So moving on to the next slide. Okay, so currently, just to review, our management for treating urea cycle disorders is very much what I already discussed in that history. We have dietary protein restriction with use of metabolic formulas or essential amino acid supplementation. We give L-arginine or L-citrulline, depending on the disorder, to drive the production of urea. Ammonia scavenger medications, I'll talk about in a little more detail. And then liver transplantation. Originally, it was for the most severe cases, but now we are seeing even more patients who may be stable and later in life electing to go ahead with a transplant. Living donor transplants has actually opened the door to provide more livers available for treatment and for transplantation in patients with metabolic diseases. And then also in times of crisis, we have Ammonul, arginine, and high dextrose containing IV fluids, intralipids, and then if we need it, dialysis. And dialysis has come a long way too. Next slide. So I'll take a little time to talk about what's available to our patients with urea cycle disorders if we put them on a chronic long-term ammonia scavenger. So I already mentioned the early development of those ammonia scavengers, talked about Ammonul and using IV L-arginine when patients are in acute crisis, when their ammonia is very high. And oftentimes that's used until dialysis is started and then maybe put back on after the ammonia's come down. There's also the chronic maintenance medications. I mentioned sodium benzoate was one of the early medications used. And then sodium phenylbutyrate, which is also known as buphenyl, that removes a little bit more nitrogen, twice as much as the sodium benzoate. However, today, because those medications were a little hard to handle because of large amounts of pills or bitter taste, there was a push to develop better treatments that were a little more tolerable that people could actually comply with. So glycerol phenylbutyrate is one, and that was developed during the 2010s, 2015. There were clinical trials. HPN 100 may be a familiar term for some of our patients on the call. And Ravicti was just basically doing the same thing as buphenyl, the phenylbutyrate, by binding glutamine and getting rid of glutamine through the urine before it entered the urea cycle. But it was a very concentrated liquid form with no taste. So people could take small volumes several times a day, keep their ammonia levels under control without having to take huge numbers of pills or very bitter tasting powders. More recently, in the last couple of years, there have been other forms of sodium phenylbutyrate that actually are more palatable. So Feburane is the medication that's in the spoon on the far side of the slide. Those are granules and they're flavor masks. So it's little granules of buphenyl that are wrapped in a flavor masking coating. Usually large amounts are needed. If an adult was taking this, it'd be 5 or 6 spoonfuls all at one time, 5 times a day. Usually put it on your tongue, wash it back. If you can't really mix it in applesauce because the coating will start to dissolve, so you can sprinkle it on top, eat it right away so that you don't have the coating dissolve or you will taste the buphenyl. The sodium phenylbutyrate powder Alpruva actually is mixed with a flavor masking agent in water. So this is another product. It is buphenyl sodium phenylbutyrate, but it is mixed in water with a flavor masking solution. You do have to take that about 5 times a day, but you can mix it in a small amount of water. And I have tasted it. There is absolutely no taste that was detectable. So next slide. So there are pros and cons to each. So I did want to spend a little time talking about things to look out for when you use these medications. So we talked about ammonol. It's the IV form of ammonia scavengers that are used in acute crises. The drawbacks are we don't know what it could do if someone's pregnant. It hasn't really been studied. It's still a class C medication, but if someone's in crisis, you still have to do what you need to do to get their levels down. The risk of using ammonol in high doses also includes neurotoxicity. So patients can become fatigued, somnolent. They can have lightheadedness, headache. They can develop neuropathy or have an exacerbation of neuropathy, become disoriented. There can be a metallic taste that patients describe when they are used on the ammonol. Some patients have hearing loss, memory loss, and at the very worst case scenario, at really high doses could develop cerebral edema. If you stop the ammonol, though, all of this is reversible. If you leave someone on high doses of ammonol for a long time, you can develop hepatotoxicity, so you can have some liver dysfunction. It can also cause marrow suppression, so you can see anemias or decreased white cell counts. L-arginine itself is also used in conjunction with the ammonol to produce more urea. The only issue with arginine is it is stabilized with a hydrochloric acid, which can be caustic to veins, so it's better to use a central line. It can be given peripherally, though, when needed. And it also is a vasodilator, so it can drop your blood pressure. Next slide. And this is just a review to give a visual of how these medications work. And I'll just do this very quickly because I think in a prior echo, there was a little more discussion about this. But basically, in review, sodium benzoate binds with glycine to form hippuric acid, and that is excreted in the urine. You get rid of one nitrogen that does not become ammonia, so it does not need to go through the urea cycle. The phenyl acetate component of ammonol binds glutamine, and glutamine contains 2 nitrogens. So the glutamine phenyl acetate combines to make phenyl acetylglutamine, which contains 2 nitrogens, is excreted in the urine, does not need to go through the urea cycle. And then the arginine is added. So the distal enzymes in people with proximal urea cycle disorders work just fine. It produces more urea. Urea contains a nitrogen, so that's another nitrogen that's released from the body in the urine that will not become ammonia. Next slide. And the buphanyl, furan, and Alpruva all work very similarly to the phenylacetate. They all bind glutamine, get rid of 2 nitrogens per molecule. The buphanyl, the problems with it is the taste, the large number of pills that someone would need to take to meet their daily dose to be able to adequately reduce their ammonia nitrogen load. They can take powder. Usually patients need a G tube to be able to tolerate the powder. It is possible to take it orally, but it's very bitter. Patients have described GI distress just from the buphanyl itself, decreased appetite. When you're taking 20 pills at a time, you're not going to feel very hungry. And one of the most common side effects is irregular periods or cessation of menstrual periods in women. And neurotoxicity can occur. It's uncommon, but even really high doses, you could see those same neurotoxic symptoms that you would see with high dose amyl. Furan is one of the newer medications. That's the one that's the pellets. That is a large amount of the pellets in those little measuring spoons, at least 5 times a day. So that can be a little hard to do so frequently in large doses, but it's doable. You cannot solve the coating, or it will be bitter, and you'll just taste the phenylbutyrate. Neurotoxicity can occur. It's the same thing as amyl, somnolence, fatigue, lightheadedness. It can affect the kidneys, so you can see hypokalemia because of effects on the renal tubules. And it also, interestingly, contains sucrose. So it's advised to avoid it in diabetics so that you don't raise their blood sugar. Also, patients who have fructose intolerance, glucose galactose malabsorption, or sucrase isomaltase insufficiency could have exacerbations of those disorders with the use of furan because of the sucrose content. Alpruva, I also mentioned, also is a frequent dosing medication, at least 5 times a day, sometimes more. It does seem to have a little more neurotoxicity. I've had a couple of patients who've tried it. One just became so dizzy that it was really incapacitating. Some patients describe headaches. You can become fatigued, confused. It's all very similar to the neurotoxicity of phenylbutyrate and phenylacetate. Hypokalemia is also an issue because of effects on the renal tubules. So those are the sodium phenylbutyrate products. Ravicti, again, just like phenylbutyrate, binds with glutamine, removes 2 nitrogens. It also has a risk of neurotoxicity, same symptoms as phenylbutyrate. Hepatotoxicity tends to be a little more common with this at high doses, so you can see changes in liver function. Pancreatic or insufficiency or intestinal malabsorption can actually be a problem. People who have those issues may not absorb as much of the Ravicti, so they might be taking a really high dose, but only absorbing a little bit because you need the pancreatic enzymes to break down the glycerol. And so this is carried in a fat, so it's almost like an oil. People, because of that oily consistency, can have some GI distress, nausea, maybe some vomiting. They can have decreased appetite, diarrhea, gas. And also it has been noted, especially in really little kids and babies, marrow suppression can be an issue. So there are people that really Ravicti just doesn't work for them. Sodium benzoate, we don't use that as much. I usually use that as an add-on when I have someone maxed out on Ravicti or phenylbutyrate and need something extra, that their ammonia levels are still kind of high, or glutamines. They need something in addition, but I can't go up any further on their dose. So I add on sodium benzoate, and I only have that in a couple of patients. It's a liquid, so it's usually easy to take. There can be some neurotoxicity because it drops glycine levels, and you need that for neurotransmitters and neurologic function. You can also have nausea, vomiting, and abdominal discomfort because it's a little bit fizzy. And people who are allergic to aspirin may have cross-reactivity with sodium benzoate, so that's a contraindication. And it's advised not to use with citric acid because that can convert the benzoate into benzene, which is a carcinogen. Next slide. And the only other medication used for urea cycle disorders that I did not have on the list at all yet is Carbaglu. So Carbaglu is the medication that's used for NAG-S deficiency in patients with CPS, certain patients with CPS1 deficiency, depending on their specific gene change. So N-acetylglutamate is the cofactor for the CPS1 carbamyl phosphate synthase enzyme, which is at the very first step of the urea cycle, converting ammonia into carbonyl phosphate. Without the N-acetylglutamate, the CPS1 enzyme just will not function adequately. So it's very easy if someone has the N-acetylglutamate synthase deficiency, you just give them synthetic N-acetylglutamate, which is Carbaglu. That fixes the problem. That's all they need. People with CPS1 deficiency, if they have changes in the gene that would benefit from extra cofactor, they may respond. So a small percentage of patients with CPS1 will benefit from Carbaglu. But that is really all you have to do for NAGS deficiency. There's no dietary management. It's just taking Carbaglu. So next slide. So moving on, we have all of those medical options for the treatment of urea cycle disorders. Liver transplant is also an option. So in 1989, I mentioned that was the first liver transplant, and that was for a patient with OTC deficiency. Over the past 10 years, especially liver transplant has become more commonplace in patients with urea cycle disorders, particularly proximal urea cycle disorders and other liver-based metabolic diseases. Living donor transplants have increased availability of livers for patients to have transplants. And the recent outcomes at the experience centers show that there's more than a 90% survival of patients and their transplanted liver grafts 10 years after transplant. So this is a very good option with longevity. And for patients who have the more severe forms of urea cycle disorders, early transplant is more common. Next slide. There was a study that was done a few years back that was proposed by the National Urea Cycle Disorder Foundation and conducted with Dr. Amiu at Children's National. It was funded by it was a PCORI grant. But what they were trying to learn is when you have families who are facing the decision to go for a liver transplant versus continue with medical management, what are the factors that help them to make that decision? For some patients, it was based solely on their clinical status of their child. So the more severe the disease, the more likely they were going to go for a transplant. So these are the neonatal OTCs, the kids that presented in the newborn period. They're much more likely to go right to transplant. If the patients were more stable and presented later on, they were more likely to opt for medical management. There were also personal factors. If there was a financial burden on the treatment, the cost of treatment, if there was many kids in the family and this child was in the hospital all the time, there were a lot of stressors within the family that may lead to an option to go for liver transplant. Also, social interactions, families who are connected with other urea cycle families who had gone through transplant, if they learned about the process and maybe it didn't seem as scary anymore, and the people that they knew had a child that went through transplant and had a great outcome, they might decide, maybe we should do it too. And also thinking down the road, how would their lives be after the parents are no longer able to take care of them? Would that child be able to manage on their own? And if not, would they be in a group home, and could the group home be able to manage their medical needs? Or would it be easier if they've had a transplant? And then the last factor was the medical system around them. If they live in a rural area and there's no specialists that specialize in metabolic diseases nearby, they may not be able to find a doctor who knows anything about their disorder to take care of them. Or if they have a hospital nearby that doesn't have D10 or dialysis or Ammonol, how far would they have to travel or be transported for care? So a lot of those factors did impact the choice to make that decision, transplant versus medical management. Next slide. So to give you an example, this is my friend Nate. And Nate was born with citrullinemia type 1. And his parents recently had to decide, do they go forward with a liver transplant or continue on the medical management that he'd been on most of his life? So to give you a background about Nate and how he came into the world, he was born after an uncomplicated pregnancy. He did fine in the newborn nursery for the first 36 hours of life. He was the first baby in the family. And no one was worried, sent him home. But after about 48 hours, he started to throw up a lot. And he was throwing up his feeds. And then he just stopped eating and he just started crying. And he was crying unconsolably for about 8 or 9 hours. Wasn't eating. He sort of just fell asleep and passed out around day life 3. It was really hard to wake him up. He continued not to eat. His parents were really worried, and they brought him to see his pediatrician, who reassured them that he was fine, babies sleep a lot, don't worry. He did some basic labs and sent them home. But a few hours later did call because he had mild hyperbilirubinemia and thought maybe he should come into the hospital for observation. So he was admitted to a hospital for 6 days of being observed. And he was lethargic this whole time. He just kept on sleeping, wouldn't wake up very well, wasn't eating. They did put him on IV fluids, which may have probably helped with some dextrose in them. They did notice during the 6-day period that his legs were moving in a cycling movement. Probably at the time, they didn't really know what those were, but it was probably seizures now that we know what we know. On day of admission 6, he stopped breathing. And his mom was holding him when this happened. And she took him out to the nurse's station. They called a code and transferred him to the ICU. He was 9 days old at the time. But instead of ordering lab tests and investigating this more, they questioned his mom about non-accidental trauma and asked if she dropped him, thought maybe he was a shaken baby, and really didn't look further, just got focused on that. He was in a coma in the ICU until he was 11 days old. And that's when they finally thought maybe we should send an ammonia level. When the ammonia was sent, it came back at over 1,500 with a reference range of less than 53. So who knows how high it had been. He was on IV fluids with dextrose that might have helped a little bit, but we clearly had an answer to why he was in a coma and wasn't responding. So at that time, they realized there was a urea cycle disorder, put him on a low protein diet, gave him high dextrose concentration fluids and butanol, but he never got ammonol and no dialysis. So gradually his ammonia came down over time. Next slide. So after that initial presentation, he actually was pretty stable until he got to puberty. And around puberty, with all the hormonal changes and growth that happens, he started to have some instability and his ammonia started to spike here and there. I would mention too, though, because of the brain damage from that high ammonia when he was a baby, he does have some developmental delays and does need assistance for his activities of daily living. So his parents were very involved in his care. At 12 years of age, he did develop gastroenteritis that triggered his first hyperammonemic event that caused him to go back into a coma. So that's the first time his ammonia got high enough to have him lose consciousness. That occurred. He had several episodes and several admissions because of high ammonia during puberty. But he eventually stabilized after puberty. And that's around the time that I actually met Nate. He was actually doing really well. He was on butanol still, but then the HPN 100 trial was available. So it was something that he ended up participating in. And when he was changed to Ravicti, which was what HPN 100 was, his ammonia actually destabilized and he became really unstable, had lots of hospitalizations due to high ammonia levels. And his liver transaminases actually went up on Ravicti. So he was switched back to butanol. But it was after that experience that his parents started thinking about transplant for the first time. And at 18, decided that maybe that's something they should consider. So the next slide. So at this point, his parents had to think about what should they do for his future. So one of the factors in their decision to consider a liver transplant was the cost of his ammonia scavenger. He was on Ravicti at that time. He actually ended up back on Ravicti. Ravicti was $120,000 per month. So it was very expensive, and they were worried about a lifetime insurance cap. Could they keep him on this forever? They would probably get kicked off at some point. They also considered, if either of his parents could no longer take care of them or both of them could not take care of him, they would probably have to consider having him go to a group home eventually. And they wondered if he went to a group home, would the people there be able to handle the specialized metabolic formulas, his dietary protein restriction, his ammonia scavenger meds? Would they know when his ammonia was high? Would they know what to look for, know what the symptoms were? Would they know the situations that could predispose him to high ammonia and be able to take him for emergency care when he needed it in time? They thought that was kind of a big ask for a group home. They also thought, well, if we did a liver transplant, could they handle giving him his anti-rejection medications each day and then once a month getting his post-transplant labs? Probably a little easier. And then also, because he was unstable on the Ravicti, and there was a lot of discussion back and forth with the physicians that were taking care of him, and not always an agreement between whether he should be on Ravicti or bufanol, and the family felt like they didn't really have a whole lot of control anymore. So they were all factors that weighed into the decision to go ahead with transplant. Next slide. So at 18, he went for his liver transplant evaluation, and at 20, he got a liver transplant from a deceased donor at UPMC, which is one of the most experienced transplant centers for patients with metabolic disorders. And now, 10 years later, almost, he is doing really well and transitioning to a group home. And because I couldn't say it any better, in his mom's words, Nate's transplant was the best thing we've ever done for him. And I mostly regret not doing it when he was 12 and became so unstable. One of the most telling things is after Nate woke up from transplant and began to recover, he repeatedly told us how good he felt and how healthy he was. It makes me think that prior to transplant, Nate probably never had a time when he wasn't feeling sick, nauseated, headachy, etc. And our family stress level has decreased dramatically. First, there isn't the constant worry of Nate getting really sick out of the blue. Nate was 20 years old when transplanted. And for the first time ever, I stopped checking in his room every night before he would go to bed. I always popped in, took a big breath to see if I smelled vomit, the first sign of high ammonia. Also, the medications post-transplant are common and easy to come by, so no worries on shortages, problems with shipping, forgetting something necessary when traveling and not having access to it, etc. And Nate's medical care is so much more mainstream. He can be seen by a wider array of physicians that know how to treat him and what to do when he has issues. Next slide. So after reviewing all of the options that we have for our patients, diet, medications, liver transplant, and acute treatment during crisis, they're still not perfect. And patients, despite all of these things, still could have an event where their ammonia goes up really high unexpectedly, and they could die or have permanent neurologic damage. The diet is difficult to follow, especially when patients aren't home or when they're teenagers and with their friends or in college. Patients may feel hungry all the time. The formula can be really expensive if it's not covered by your state or by insurance. Medications, the ammonia scavengers, are very expensive and do have potential side effects. And liver transplant, while it's pretty effective and more than 90% of patients are doing great 10 years later, there's still a risk of complications. And there's always a risk with any major surgery, like a transplant, of death. It is a major surgery, so it's a long recovery. You have to have a suitable donor, so there's no guarantees how fast that will happen. And then there's long-term use of anti-rejection medications with subsequent immunosuppression, the risk of rejection or failure of the graft, and potentially requiring a second transplant. And it's expensive to go through a transplant. And in the acute treatment in a crisis, as I mentioned, there's side effects to lots of Ammonol. Dialysis isn't without risks or side effects. It's expensive, and it's not available everywhere. And I mentioned you can have complications from dialysis too. So that leads us into our next half of the session after we take a break about what do we have in development that may be better than what we have now. Time to move on to the next part. So this is, I think, really exciting. This is the section that we get to talk about our new treatments that are in clinical trials and or treatments that are just about to be approved. So it's very exciting to even have these options for patients. And it seems like in the last few years, the options for clinical trials and potential future treatments have just exploded. So next slide. So I'm going to start with the clinical trials that have been completed in recent years. So first, I'm going to mention pegcetacoplan. So that is an enzyme replacement therapy for arginase 1 deficiency. And this has been through clinical trials. The clinical trials, phase 3, showed really a good benefit for patients with arginase deficiency. And so this is the last enzyme in the urea cycle. So those patients are not producing arginine. or they're not breaking down arginine effectively to continue pushing the urea cycle. So they have a buildup of arginine, very little urea production, and then they're not closing the loop back to ornithine in the urea cycle. So for these patients, there is an enzyme replacement therapy, and I'll talk a little bit more about it in the next slide, but it is pending FDA approval in the US. It's available in other countries. And just quickly, I wanted to mention a couple of trials that occurred in the last decade or so that initially sounded like they would be amazing, but they didn't really pan out. And I only mention these because we have to do clinical trials to learn what works and what doesn't. So there were 2 trials in the US, and what they involved was actually injecting hepatocytes or human liver cells from donors into the portal vein to get those cells directly into the liver. And it sounded really cool and like it would be a great option. Basically, they were giving healthy hepatocytes to have some urea cycle function in usually patients that had very severe proximal urea cycle disorders, just to bridge those kids to transplant, and to give them a little more time to grow and to give them some stability. However, after enrolling about 10 patients, that trial stopped because it just didn't seem to be doing what was expected. There was another similar trial at UPMC, also ended after enrolling about 5 patients. And that was the most recent. That ended in 2022. And that was for patients with multiple metabolic disorders, not just urea cycle disorders. And then there was also a similar trial in Europe, also ended abruptly, no results posted. So in general, they gave that a try. It didn't work like anticipated. So next slide. So we currently, this is from the NUCDF website, have multiple companies that are working on treatments for patients with urea cycle disorders. And I'll talk about 3 of them, the ones that are in the phase 3, phase 2 phases in the clinical trial. So they're in trials currently. And I'll also just quickly talk about pegylaronase, which is pending FDA review. So I guess that's the phase 4. Next slide. So as I mentioned, pegylaronase is an enzyme replacement therapy for arginase 1 deficiency. So you get really high levels of arginine because you're not breaking down the arginine, not making urea, and not forming ornithine again to keep driving the urea cycle. It was known as the PEACE trial. And basically, to give you a quick overview, it showed a 76.7% reduction in plasma arginine levels in these patients. And in over 90% of patients who were treated who had arginase 1 deficiency, they actually had normal arginine levels, which is pretty amazing. And not just did they see the effects in the clinical lab results, but they also saw an improvement of their motor function. So the patients actually gained mobility. So patients with arginase deficiency actually can develop spasticity, and that can affect their movement. So there was really good data showing improvement. However, the FDA hasn't said no, but they wanted more data to support the effectiveness. So that's kind of where that sits in the US, but it's approved in Europe and being manufactured by Medica as Loargis. So some of the doctors on this call might have access to this for their arginase 1 deficiency patients. Next slide. So moving on to another group of treatments are mRNA therapies. Next slide. So currently for patients with OTC deficiency, there is an ongoing clinical trial where mRNA, the mRNA transcript that's made from a working copy of an human OTC gene, is injected using lipid nanoparticles. So this is very similar to the COVID vaccine, where you inject an mRNA sequence, and that mRNA sequence codes for a working copy of something. And in this case, it's the working copy of the OTC enzyme. So they did this preclinically in mice. So they injected these lipid nanoparticles carrying mRNA that coded for the OTC enzyme into the mice. It was directed to the liver. And what they found was that the mRNA would get into the liver cells, it would be released, it would be translated into a working OTC enzyme, and that would restore some function of the urea cycle, and they would see a reduction of ammonia. So after this was thought to be pretty successful in mice, they moved on to treating humans. Next slide. So currently, there is an ongoing mRNA trial for patients with OTC deficiency. It's in the phase 1/2 trial state. So this is first in human. It's a dose finding safety trial. So these patients are not blinded. They know they're getting the medication. And their goal is to get 9 patients enrolled. And it has to be anyone over the age of 12 years with OTC deficiency who's had a history of symptomatic high ammonia or elevated glutamine levels. And they have to be on a treatment with an ammonia scavenger, protein restriction, so they can tell if there's a difference after treatment. And anyone who's had gene therapy, a liver transplant, or received the hepatocyte transfer, they're not, in the past 2 years, are not eligible. Next slide. So for the patients that are enrolled, the whole study only lasts 85 days. So they're getting 5 doses of the study drug, which is known as ARCT-810 via infusion at one of the 3 dose levels, either low, medium, or high. And they're doing ureagenesis studies to look at if there's an improvement, increased urea production in these patients, and they're using a radio-labeled isotope to measure this. Ammonia and glutamine levels are monitored to see if there's improvement. And the only thing with this trial is patients have to go to the one site that is enrolling patients and doing the trial. So they have to be mobile. Next slide. So I have just a little bit of information that was shared at the ICIEM meeting in Kyoto. Generally, what is public and reportable is that the mean glutamine levels, so the average glutamine levels, which is typically elevated in patients with OTC deficiency, significantly reduced over time after treatment with the mRNA. Once they stopped giving them the mRNA therapy, the glutamine levels went back up. So this is something that if you had an mRNA treatment, this would be injections every so often ongoing. So this isn't a one-time thing. This is a injection every so often. So basically what they're seeing from this is that glutamine can be used as a good marker to tell if this medication is working. And more to come in the future. That's all the information I have at this point about this one. Next slide. So our next group of new treatments is gene therapy. So currently we're using adeno-associated viruses as the vector to carry the working copy human OTC gene into the liver cells. And that's in contrast to adenovirus, which was used in that original gene therapy trial. Even though they're named similarly, they're very different. AAV is much safer than adenovirus. Not that there aren't potential risks, but patients generally tolerate it well. AAVs are out in the community, so you can be exposed to them without knowing it. Most people don't have any symptoms. In the current clinical trial that's being done, AAV8 is the vector that's being used. So about 50% of people already have antibodies to this. So if you have antibodies already, you're ineligible for the study because your body will just attack the virus and it won't go anywhere. It won't be effective. So in the patients that are eligible that do not have antibodies, they receive a one-time infusion of a high concentration of AAV8 viruses that have been engineered to carry a working copy of the OTC gene targeted to the liver. And those viruses are taken up by some of the liver hepatocytes, and the virus starts to replicate its genome. And because the OTC gene has been inserted into the viral genome, that also is translated so you're theoretically making OTC working enzyme in those cells that have the virus living in them. And the virus just sticks around. It's kind of like being infected with, I'll use for an example, maybe it's not the perfect example, but chickenpox. If you were exposed to varicella, you have your infection, but then it still kind of hangs out there in your liver for years. So we don't know how long the AAVs will stick around. That's why we are still in long-term follow-up studies. But theoretically, it will last and not enter into the human genome. So it won't affect the person's DNA. So next slide. So I kind of gave you the general overview of how it works. The whole point of the currently the gene therapy trial for OTC deficiency is in phase 3. The phase 1/2 trial is complete and already closed, and data is being reported, but all those patients are long-term follow-up. So the whole goal of the gene therapy trial, and the gene therapy that was used is DTX301. So that is the gene therapy, the AAV8 virus that carries that OTC gene. The goal is to get ammonia and glutamine levels to come down in those patients that are treated, to reduce the amount of ammonia scavengers that those patients need to take, or even get them off of ammonia scavengers, to ease up on their dietary protein restriction, to be able to give them more protein, or even liberalize their diet, and maybe even get them off of metabolic formula. Also to help stabilize them so they can tolerate illnesses, physiologic stress without going into hyperammonemic crisis. So that's the goal. And as I mentioned, it's given as a one-time dose. And I'll move on to the next slide to give a little more insight into how the phase 1/2 trial went. So for the patients that were eligible, these were adults who were over the age of 18. They had to have stable OTC deficiency with no liver disease associated. They were not able to have had a hyperammonemic event for at least 28 days before screening. They had to be on an ammonia scavenger and a dietary restriction, and 11 patients ended up enrolling. So there were 4 cohorts. Cohort 1 got the low dose of the gene therapy. So the whole point was to find out what's the most effective dose that's also safe. So the low dose was cohort 1, 3 patients were in that group. The medium dose, cohort 2, that was 3 patients. Cohort 3 was the high dose, which seemed to be the most effective and safest. Those were 3 patients, but all of the patients that received that gene therapy ended up having transaminitis. So their ALT, AST, and their liver function tests went up. And this was not unexpected. That had been seen in other AAV gene therapy trials. So the patients were treated with steroids, high-dose steroids, for a period of time to keep that inflammation in the liver from that large viral load under control. That had been done in other trials too. So cohort 4 was the group that got the highest dose, but also were prophylactically given high-dose steroids. So we didn't wait for their liver function test to go up and then treat. We just treated them expecting it to happen. And the goal was to try to keep that inflammation from happening, because you could lose some of your vector if your liver becomes inflamed and your immune system starts to go after that virus. So all those patients went through the dosing. They knew they were getting it. It was not blinded. They went through 52 weeks of study monitoring, and then the study ended, and all 11 patients rolled over to an 8-year long-term extension trial, and we're still following those patients to see how they're doing and how long this lasts. Next page or slide. So the goal, as I mentioned, was to increase protein intake, reduce ammonia scavengers. A complete responder was defined as a patient who got off of their ammonia scavengers completely and also could liberalize their diet and not have to have a protein restriction anymore. And there were 3 patients who that was the case for, so that was great. Some patients were responsive and had some benefit. They had at least a 50% reduction of their ammonia scavenger dose, or had a 50% increase of their protein intake in their diet. So there was some improvement of their life. And then there were a few patients that did not respond. The changes were made in the ammonia scavenger drug doses or dietary intake based on their labs and how they were doing clinically. Next page or next slide. So it was found, just in general, I put a lot of information on here, but I'll give you the highlights. There were no serious adverse events associated with the DTX301 gene therapy. We did have there were patients that did have some asymptomatic increases of their liver transaminases, especially ALT. However, that was expected. They responded to the high-dose steroids. That all simmered down. And otherwise, other than just some very minor things like nausea, vomiting, they happened over time as AEs. There was nothing really major. So it was determined that the DTX301 was pretty safe, aside from the expected liver function bump that was easily managed. Next page. There was and some adverse events related to steroid use, though. So these are high dose steroids. And in the phase 1/2 trial, the steroids were used for a longer period of time. So there were some common things that you expect with steroids, like weight gain, increased appetite, emotional lability. Those all resolved after steroids were stopped. But one patient did have a grade 3 adverse event with bone infarction, osteonecrosis, and subcortical collapse requiring a knee replacement. So that is a known potential side effect for high dose steroids that happens in 10% of people. So this isn't something that's unheard of, but it wasn't necessarily expected. So none of the other patients had that kind of reaction to the steroids. So it's something to keep in mind. Next page or next slide. So this just gives you a visual of all of the patients. And as I mentioned, 7 of the 11 patients had some meaningful response to the gene therapy. 4 were complete responders. Sorry, I think I said 3. 4 were complete responders. 3 were responders. Complete were off of ammonia scavengers with normal diets. So there were 4 that were complete, 3 that were responders, and then the remaining were not responders. But overall, when you looked at the group as a whole, the ureagenesis studies show that the ureagenesis increased by 77% in all patients, not just the responders, but also including the non-responders. And then plasma ammonia levels declined towards normal within 6 weeks of the gene therapy administration. Next slide. And currently, that same gene therapy is being used as a phase 3 clinical trial. It's a double-blinded, placebo-controlled study with crossover, meaning patients are randomized into 2 groups. Half of the patients approximately half get placebo the first time, and then months later at the crossover get the gene therapy, or vice versa. It's for patients 12 years and older with OTC deficiency who've had at least 1 episode of symptomatic hyperammonemia. And it's close to enrollment now. At this point, all patients are in the study, going through unblinding at this point. And we don't have results to share at this point, but over in the future, there'll be more to share. Next slide. So I did spend a lot of time on gene therapy because that has been ongoing for many years, and it's the only one in phase 3 trials. But there are newer treatments that have come out in the last couple of years using gene editing. So next slide. So currently there is a gene editing clinical trial that is the first being used in urea cycle disorders. It's the OTC HOPE trial. And this trial is using CRISPR-Cas9 technology to insert a working OTC gene into the patient DNA. And this is being used in male infants with OTC deficiency with severe neonatal onset. So they're getting sick within the first days of life. They have to be under 9 months of age to be treated. It's a phase 1/2, and then there'll be a phase 3 trial. They're using an adeno-associated vector to carry the CRISPR-Cas9 gene editing material into the liver cells. And they began enrolling in 2024. They're hoping to finish by September 2023. There's 3 sites enrolling in the US. Next slide. And the way that they're doing it is they are using the AAV vector. And some of the AAV vectors carry the nuclease, which is the enzyme that cuts the double strand of DNA in the patient. And it's targeted to a specific gene. So in this case, they're targeting it to the PCSK9 gene, which is a cholesterol gene. So interestingly, when they cut that gene in the middle and pop the working OTC gene in and insert that into the patient's DNA, they actually also disrupt a high cholesterol gene. So the patients have low cholesterol. So lower risk of cardiovascular disease and potentially could treat their OTC deficiency. So it's pretty innovative. The reason they picked that specific gene was because it has a unique sequence as well. So there's less off-target effects. At least that's the goal. It is possible when you're using gene editing technology that you can accidentally cut the DNA in other places and disrupt genes that you don't mean to. So there are some downsides to it that are potentially risk. Next slide. So the first patient that was treated with this gene editing treatment, which is it's called eCure 506. There is information about patient one. This was presented at the ICIEM meeting in Kyoto a couple months ago. And basically, they're just showing how the first patient did over a 10-month follow-up after dosing. So this is a little boy with severe OTC and had a couple of really severe hyperammonemic events. He was given the dose of the gene editing treatment around 6.5 months of age. Prior to that, he'd been on phenylbutyrate and protein restriction, which is pretty typical of what we would do for an OTC deficiency patient. He received his gene editing treatment, and after treatment, they were able to wean him off of his phenylbutyrate and then start to give him more protein to the point where he actually went on a normal diet. And now he's being followed with no ammonia scavenger, regular diet, and they're following him, and so far so good. So next slide. So this just is giving visual of the reduction of the phenylbutyrate. So basically what they were seeing at around 8 weeks, they noticed that the patient's glutamine levels actually were less than normal. They were below the reference range. So that gave them a clue that they could go ahead and start weaning his ammonia scavenger. So they saw him every week, weaned him a little bit more until he was off by week 13 after the treatment with the gene editing. Then they started to liberalize his diet around week 12. And by week 15, he was on a normal diet. They watched as his BUN increased. And that indicates that there is an improvement, increased production of urea by the urea cycle, and his average ammonia came down. And the report indicates that he had no further hyperammonemic crisis for at least the 10 months that they followed him after treatment, and they took the kid off the liver transplant list. Next slide. So there are two different ways to do gene editing. And the CRISPR-Cas9 is kind of the classic gene editing that people think about and have heard of, but then there's also base editing. So the difference is for the CRISPR-Cas9 gene editing, you cut the patient's DNA, both strands. You can insert whole genes, sequences, delete portions of the genome. You can modify genes, but it can be used on a variety of tissues. The only downside that I mentioned is the off-target effects, where you could disrupt a gene in the wrong place, maybe turn off a tumor suppressor gene, create a new disorder that the patient didn't have before. So there are risks with this. Then there's base editing, which does not cut the DNA, and it only makes very precise changes to specific DNA bases or nucleotides within a gene where there is a misspelling. And it can only fix certain misspellings. So if you have OTC deficiency or another urea cycle disorder or any disorder that they're trying to treat with base editing, you have to have a point mutation that would benefit from changing either a C to a T, so that's using cytosine base editors, or an A adenine to a guanine, so an A to a G. If you have a mutation that would help correct the gene function by just making those little changes in those point mutations, then great, you can use base editing. But so it's very specific. You can only change it use it for certain mutations. And so it cannot do large scale genome modifications. It can't insert an entire gene, but it is more controlled and you can predict the gene edits and there's less risk for off-target effects. Next slide. So many people have probably heard about this little guy. This is KJ, and he's a little boy with CPS1 deficiency who had classic severe CPS1 deficiency. He got sick within the first couple of days of life, had a very high ammonia, underwent the same usual treatment with ammonia scavengers, dialysis, all of the usual things. And he went through gene editing around 7 months of age using base editing. Next slide. So this was in the New England Journal of Medicine and all over the news. But for this little guy, they produced a personalized gene editing treatment just for him and one of his mutations that would be amenable to base editing. So as I mentioned, he had the usual severe hyperammonemia, ammonia was 1703, the usual dialysis, ammonol, high dextrose lipid treatment. And then he was just put on the usual treatment with Ravicti, as an ammonia scavenger, citrulline, and low protein diet with metabolic formula. They confirmed his diagnosis. He was stable for a little while, but then started to have hyperammonemic events around 100 days of age. They listed him for liver transplant at 5 months. But during this whole time, they were working on this personalized gene editing therapy to use for him also. So he had more than one option. Next slide. And I will only just briefly go over the key points in this diagram. The key point is this baby did not have a prenatal diagnosis. He was diagnosed after birth, and they pretty quickly developed this base editing treatment just for him. And they looked at his mutations. They found that one they could use base editing for. They created a cell line, did testing. They used mouse model that they engineered his mutation in. They looked for off-target changes in the genome. They didn't find anything significant. And they went through a lot of preliminary testing to very quickly create this treatment for this baby and get it approved by the FDA and treat him by 7 months of age. And because they were using a lipid nanoparticle to carry the base editing treatment, they could redose because the lipid nanoparticles you don't develop antibodies to. Next slide. So he received a second dose at 8 months. And this little guy tolerated both doses without any problems. They were able to cut his glycerol phenylbutyrate dose in half. And this is what was reported at the ICIEM meeting. He, after treatment, got through a couple of episodes of viral illnesses that would normally trigger a hyperammonemic event without having any decompensation. He continues to remain stable, but he still requires treatment with ammonia scavenger and dietary protein restriction with metabolic formula. So he's not off of treatment, but compared to where he was, he has a much milder form of CPS1. It's unknown how long this will last. It's unknown if he will avoid a liver transplant. He still might need that long term if this doesn't have a long duration. They just don't know. And they need to continue following him. Potentially, he could get more doses of the treatment, but the treatment only can be used for him, or if there was someone else who happened to have the same mutation that the treatment was aimed for. Next slide. So I guess that is not generalizable to the whole population of urea cycle disorder patients yet. So the risks of gene therapy and gene editing, AAV vectors can cause a hyperinflammatory response, as I mentioned, and causes inflammation of the liver post-dose, and that's why we have to give high-dose steroids. Potentially, you could use other immunosuppressants to decrease that response. Microangiopathy has been noted in patients with other metabolic diseases who've had gene therapy. So that is a risk. Microangiopathy just means there's little clots in the small blood vessels. So that is a risk. There have been deaths in the small number of patients who've received AAV gene therapies, some from liver issues. Some were patients with muscular dystrophies that were being treated that had cardiomyopathy already. So there were some complications related to that. And there are side effects of steroids, as I already mentioned earlier. And so there's some consideration of using other immune suppressants. And then for the gene editing, there's the potential for off-target effects, editing a gene you don't want to, disrupting a gene, turning off a tumor suppressor. We don't know. We haven't had enough experience to know exactly what could happen. And then with traditional gene therapy, there's always that thought that could some of the vector sequence be inserted into the human genome? Theoretically, maybe, but that hasn't been seen. Also, other limitations, when gene therapies do become available, they're really expensive. So could there be problems with insurance coverage, affordability? And for patients getting AAV-mediated gene therapy, if they have antibodies, they can't get that gene therapy, or after they've been dosed, they have antibodies and can never get it again, so it can't be redosed. And then there's the hepatocyte turnover. So babies are turning over their liver cells and making new liver cells and replacing others as it grows pretty frequently. Older people, that turnover is not as fast, but that could affect how long a gene therapy could last. And then there's also no information in any of these treatments in pregnant or breastfeeding women. Next slide. So in the preclinical pipeline, there are plans for gene editing via CRISPR-Cas9 for citrullinemia type 1, and then base editing for all 7 urea cycle disorders from the same group who did the base editing for baby KJ with CPS1, although they're looking at doing base editing for more common mutations seen among patients with these 7 urea cycle disorders, so they can actually have a clinical trial and generalize it to more patients. Next slide. And this is it. So thank you. There's several people who are really, really important in helping put this together. Teresa Warner, Jill Williams, and Lori Shockey from the NUCDF. Dr. Diaz shared information about the gene editing trials through IECure. Dr. Merritt also helped share information with me for the gene therapy trials through Ultragenics. And then Dr. Summers offered information about the mRNA trials through the Uncommon Cures. And that is it.
Sorry, I was muted. Laura, thank you. That was fantastic and so jam-packed full of information. We don't have a lot of time left for questions, but we do have time for a few. So if anybody has questions, please unmute and feel free to ask them, raise your hand, or put them in the chat. And maybe just to get things started, Laura, if you have a patient coming to you, how do you advise them on making decisions with all of these options now available?
I think it depends on the patient's age and what their diagnosis is. And for adults, the AAV-mediated gene therapy trials currently are not enrolling anymore. So a couple of years ago, I would definitely have offered that to them as an option. I think you have to be clear with patients. These are clinical trials, so we don't know for sure that they'll work. We don't have that data yet, but we only will know if they work if people are willing to try. So that, and patients with urea cycle disorders have been so willing to do these trials to help better lives of future patients with the same conditions that they have. So I think for adults, traditional gene therapy with AEVs may be the route to go in the future. The gene editing seems more of something that would work better in a baby. They do rely on the gene or the cell replication to spread that change in the patient's genome to the next cell to replicate it. So it's kind of spreads throughout more of the hepatocytes. They may not happen as quickly in adults who aren't reproducing their hepatocytes so rapidly. So I think that those are options. The mRNA therapy also an option. I think that one, it would depend on the family situation to be able at this time to go to the trial center. But it also is just a few doses to see if it works. Maybe in the future it would be more long-term. So they would go get the mRNA, see if it works. But then at this time, as far as I know, they're not continuing to receive the medication long-term. But it would also be an option for them in the future, though, because if it works, then it becomes clinically available and they could continue with treatment. So I think that trial probably could be anyone over the age of 12. So I just really think it depends on the family, their situation, the age of the patient, and their severity. The gene editing trials are only going to be right now newborn onset males with severe disease who are under 9 months. So it's a very small group of patients. So not as generalizable yet.
And we wanted to let you know about an upcoming event that's taking place at the Baylor College of Medicine and via Zoom on Tuesday, December 2nd at 1 p.m. It will be the first event in a new annual series called the Cynthia Lamons Lecture Series. featuring a talk by Dr. Brendan Lee. You can scan the QR code on your screen, or I believe Teresa's going to put the link in the chat where you can also register. And, speaking of future events, we are beginning to plan our ECHO webinar series for 2026. So if you have questions that you'd like to see discussed or topics you'd like to see addressed in next year's series, please reach out to me or Teresa, and we will be happy to put those into the mix. Finally, can we go to the next slide? There we go. That is our evaluation link. If you could take a minute to complete our evaluation form for this session, we really appreciate your feedback. Also, if you're a medical professional seeking CME credits, we'll need you to submit that evaluation form. So thank you, and please stay tuned for our 2026 ECHO series coming soon.